طيب بسم الله الرحمن الرحيم السلام عليكم ورحمة الله وبركاته. Can you hear me in the back, the audience? If yes, please raise your hand. Perfect. So thank you, Mr. Chairman, for this kind and warm introduction that I do not deserve. And it's a pleasure to stand here before you to present a few slides on digital vasculopathy in systemic sclerosis. I really would like to thank the scientific committee for giving me this opportunity and inviting me to this beautiful city. And I would like to congratulate both the scientific and the organizing committee on the success of this conference, again, in this very beautiful and blessed city of Al-Madinah Munawwara. So, can I have the... Perfect. So let me start with this case scenario that we had in our scleroderma clinic. So this is a 48-year-old woman who in July 2017 started to complain of pain, numbness, and color changes of her fingers, as well as acid reflux. At that time, she was in Syria, and she was treated with some symptomatic management. And then in February 2018, she started to show some skin thickening, which started in her hands, and it progressed then to involve her arms, face, and feet, with associated fatigue and arthralgia. Then in December 2020, it was winter over there, and then she started showing worsening of her Reynolds phenomenon as well as telangiectasia. So she was diagnosed at that time with CRIST. However, she was not receiving anything with the exception of symptomatic management in form of painkiller as well as PPI. January 2022, she she traveled and stayed in a Taif city here in Saudi Arabia, which is like a cold city. And then, she started to have like significant digital ulcers and blackish discoloration of her, middle finger. As you can see here, that her past medical, past surgical history is unremarkable. Family and social history are both unremarkable, especially with no history of Reynolds phenomenon or any systemic rheumatic disease in the family. And with the exception of PPI as well as NSAIDs, she was not on any other medication. So when she showed up to our clinic, at that time, she was having normal general and vital signs. Her skin examination was showing tight and shiny skin over her hands, arms, feet, face, legs, and feet as well, with a modified Rodnan skin score of 9. Her vascular examination was showing multiple digital pits, ulcers, as well as a gangrenous, in fact, it was like left middle finger. A cardiorespiratory examination was unremarkable, as well as her musculoskeletal exam. So upon her first presentation to the scleroderma clinic at a neurospecialist hospital, you can easily identify the number of digital pits that she's having, especially on the little finger, along with forming ulcers, skin thickening, and you can see here like a necrotic and ischemic left middle finger. So at this time, the question that we were having among our team, how to manage this patient, whether we start like IV prostaglandin after admission and then wound care and antibiotics, or we discharge this patient home on outpatient oral vasodilators with wound care and antibiotics, or we should refer this patient for endoscopic thoracic sympathectomy, or we refer her to amputation. So over the next 20 minutes, I'll be walking you through some of the the following points. So we will recall some of the basic science of digital vasculopathy. We'll approach a patient with digital vasculopathy, and we will discuss the management of a patient with digital vasculopathy in light of the current evidence that we're having, as well as the lack of the management guidelines. So meet Dr. Maurice Reynolds, who lived like 200 years ago from today. And at that time, he was writing his doctoral thesis and on local asphyxia and symmetrical gangrene of the digits, and he described a phenomenon as cyanosis at the tip of the fingers, which is followed by vermilion red discoloration. This phenomenon, and then it was named after him as Reynolds phenomenon, which is an exaggerated vascular response to stimuli, which is characterized by well-demarcated color changes. The color changes always start like white, blue, and red. They can be either white or red, and so we can have either trifasic or biphasic color changes, and we have to have these changes to be able to call a patient as having like Reynolds phenomenon. Some of the epidemiological Facts about this phenomenon is that it's a phenomenon that affects like younger women, young age group, as well as family members of patients with Reynolds phenomenon. White women are more, affected compared to other genders and ethnicities. The whole pathogenetic mechanisms in Reynolds phenomenon lies in the, increased vascular anastomosis at the level of microcirculation. Physiologically, we have what we call, vascular beds. So what happens in patients with systemic sclerosis or Reynolds phenomenon, that they tend to lose this functional or physiological effect of the bed, which then results in the, disability of the blood to circulate in the microcirculation, which leads to vasoconstriction with the help of the factors that lead to the vasoconstriction. Now, in systemic sclerosis, there are multiple factors that contribute to systemic sclerosis with regards to the vascular disease. So we have like the vasospasm, we have ischemia, reperfusion injury, vasculopathy, as well as coagulation, and that's why sometimes you see patients who are on treatment for either digital ulcers or Reynolds phenomenon who are on anticoagulation for their disease. This is the biphasic, and I think this is a basic. We know that like Reynolds phenomenon is either primary with no abnormal nail fold capillaries or positive serology, or it can be secondary with the presence of some symptoms or in association with a related illness. Just to recall how to differentiate between both primary versus secondary, and I think this is for our junior colleagues in the audience. So usually secondary patients are older compared to the patients with primary. They're mostly men. However, we don't have like enough studies to have like an exact number. There is a known precipitant, painful, severe events, as well as, so the last two or sentences are the most important, because in secondary you have like abnormal nail fold capillaries, and this is something that we don't see in patients with primary, as well as we tend to see positive ANA in patients with secondary or other abnormal blood work suggestive of a secondary etiology for the Reynolds phenomenon. And of course, a Reynolds phenomenon, which is when it is associated with ischemic signs or symptoms like proximal to the fingers or toes. Again, this is like suggestive of a secondary in etiology. There are multiple etiologies. I would like to focus on the rheumatological, and here as you can see that systemic sclerosis comes at the top of the list, where you can have 95% of patients with systemic sclerosis who present with Reynolds phenomenon. This is followed by MCTD, SLE, inflammatory myopathies, and then rheumatoid arthritis. So UpToDate presents a very beautiful approach to a patient with Reynolds phenomenon. First of all, we have to make sure that this patient is really having Reynolds phenomenon, because patients might describe or misnomer like Reynolds phenomenon by just mentioning that they're having some sort of numbness. Numbness and pain is not enough. You have to see like the either biphasic or triphasic color change to be able to diagnose this patient with Reynolds phenomenon. Then the next step is to try to differentiate between primary versus secondary, and then in the third step, which is in the next slide, when it is secondary, then how to differentiate between other secondary causes and causes which can be systemic rheumatic diseases, which are on the right side of this slide. Okay. These are the set of investigations, as well as some vascular tests that we can perform in our patients. And I think with the exception of the vascular examination at the right bottom corner of this slide, I think all of these investigations can be done in any place. So it's very helpful to institute these investigations to try to differentiate among the different causes of Reynolds phenomenon. Nail fold capillaroscopy is a very important, diagnostic tool in assessing Reynolds phenomenon, and also, predicting the progression of Reynolds phenomenon. Number one, to systemic sclerosis. Number two, to the organs that might be involved, in the future. So if you can see, figure A can show you normal, parallel, capillaries, and then if you compare it to figure B, where you can see some loss of the capillaries, as well as beginning of the dilatation of the capillaries, then figure C, where you can have like an active pattern where you start to see like more and more loss of the capillaries, along with there is nothing like no uniformal patterns such as picture A and B, and then of course in D you don't see any capillaries, or you can barely see some of the capillaries. However, they're far away from the digital or fingertips. In a busy clinic, I think it's not easy to assess like the severity of Reynolds phenomenon. However, for example, if you would like to apply the Reynolds condition score, which is like a very simple score where you can assess the severity of Reynolds just by asking the patient to score the severity of the symptoms on a score from 0 to 10, where 0 there is no difficulty, however 10 like is in extreme difficulty, and then you can use this like in follow-up of these patients in the clinic. Moving on to the last part of the talk, so to talk about the management of patients with digital vasculopathy, we need to remind ourselves with the stages that we have in patients with digital vasculopathy. So the first stage is Reynolds phenomenon. This can be followed by either digital pits or ulcers if left untreated, and then of course digital ischemia and gangrene again if left untreated. So each of these stages require individually tailored medications depending on not only the severity of the Reynolds phenomenon, but also to the other comorbidities that our patients can suffer from, as well as how much their blood pressure tolerate the addition of vasodilator therapy, because this is very common practice in the clinic, that most of our scleroderma patients, they usually present with a low systolic blood pressure to start with, so it makes it a little bit difficult to control these patients' Reynolds phenomenon, and trying to apply some of the non-pharmacological modalities in managing these patients' digital vasculopathy. These are some of the non-pharmacological modalities that we can always advise and apply them on our patients. And if these fail, then we can definitely move further to the pharmacological management. Now, as of the most recent EULAR recommendations for the management of Reynolds phenomenon in patients with systemic sclerosis, you can see that we have only 3 medications that are still in the list. So the calcium channel blockers, as well as the IV prostanoids, followed by the fluoxetine. Now, as you can see that over the past few years, we have had like several additions into the vasodilator, list of medications that we can use to treat our patients. And these are the following. So we have the calcium channel blocker, where we can have like nifedipine is always on the top of the list. One reason is that it's like long-acting medication, plus it's the medication that is mostly studied in these patients. However, other calcium channel blockers can also be used in patients with digital vasculopathy. This is followed by phosphodiesterase inhibitor therapy. We have, of course, like you can see, the alpha blockers, such as prazosin, and I'm not seeing our colleague Dr. Nizar Bakhsh and Dr. Abdul Majid Aswad. They presented a very beautiful case report on managing a patient with addition of prazosin to the vasodilator therapy, and they were able to stop the formation of digital ulcers. You can see their poster in the poster exhibition area. And other medications, such as like some topical medications, nitroglycerin. We can also have the selective serotonin reuptake inhibitor. We all know that serotonin is a potent vasoconstrictor, and that's come the theory of treating these patients with the SSRIs in an attempt of relieving their vasculopathy or vasoconstriction. And of course, not to forget like a very important class, which is prostaglandin, either prostaglandin I2 or prostaglandin E analogs, which are all used in the management of patients with digital vasculopathy. Now, we do not have like other than the EULAR recommendations that I mentioned. Unfortunately, we don't yet have like solid like recommendations for the management of patients with Reynolds phenomenon in systemic sclerosis. However, over the past few years, there have been several attempts in establishing some of the pathways in managing these patients. So the pathways, so we have like 3 pathways. The first pathway is for Reynolds phenomenon, followed by a pathway for digital ulcer, and then followed by a pathway for digital ischemia. So let's start with the pathway of Reynolds phenomenon, and I would like to borrow your attention to rectangle number 4. I'm not sure if we have, it's okay, sorry, number 3. So if your non-pharmacological treatment modalities become ineffective in the management of patients with Reynolds phenomenon, here you start instituting your vasodilator therapy. Of course, the first line is a calcium channel blocker. You can always combine it with other vasodilators depending on the blood pressure of the patient. You can also add antiplatelet and statin therapy. If that proves to be effective, then fair enough. If not, then you can move on to box number 5, where you can consider this patient as having refractory Reynolds phenomenon, and then you can treat these patients with IV prostaglandin. And again, if that is effective, then fair enough. If not, then you can also add phosphodiesterase inhibitor. In our clinic, we usually prefer PDE5 over like IV prostanoids, just because of the ease of use. Plus, sometimes it's not always easy to find IV prostacyclin, and I think most of us do that in the clinic as well. Now, if our patient, unfortunately, despite doing all of that, fails the to have his Reynolds phenomenon controlled, or if the patient start showing us like digital ulceration, then of course we will have to expedite the management with involvement of other multidisciplinary teams that definitely have a major role in the management of these patients. For example, surgery for debridement, plastic surgery, wound care. And this is what we have to make sure before even starting like the vasodilator, that we have to institute all these management plans along with the IV antibiotics, because these patients most likely tend to have like gram-positive infections in their digits. And then again, always we have to think of optimizing the vasodilator therapy with the use of either IV prostaglandins, on repeating it like every few months if again things or the situation permits, again optimizing the vasodilator therapy. Now, if our patient fails that and unfortunately progresses to digital ischemia, and this is what happened with the patient that I started this talk with, then of course we have to admit these patients. We have to again optimize the vasodilator therapy, try to repeat the prostanoid or IV prostacyclin infusions, and of course consider surgical debridement. And if all of this does not work, then we can further add either the temporary sympathectomy or permanent sympathectomy, again depending on the symptoms of the patient. Now, let me take you through or walk you through some of the evidence base that we have in these medications. So, bosentan, which is an endothelin receptor antagonist, it was, shown to be effective in reducing the number of new digital ulcers in both RAPID-1 as well as RAPID-2 studies, compared to, patients who were not treated with bosentan, or they were on placebo. This medication can be instituted after treating the active digital ulcers in patients, or it can also be used as a vasodilator therapy in these patients. However, we have to make sure that the blood pressure of our patient is permitting that. Sildenafil, in a high dose, you can see here that it was given at a dose of 200 milligram. I don't think we do that in our clinic. We maximally can go up to 100 milligram, either giving it in a dose of 25 QID or 50 BID. In the West, they have a different dosage pills, 20, 30 milligrams. So it's a little better to able to tailor the medication depending on the blood pressure. However, it was an excellent medicine that has shown to be able to reduce the frequency of Reynolds attacks in patients with established Reynolds phenomenon secondary to systemic sclerosis. So we can keep that in the back of our head and in our bucket list for the management of patients with Reynolds phenomenon or digital vasculopathy in general. Now, how do patients with digital vasculopathy do over the years? You can see here in this slide that we still have huge unmet needs in the management of these patients. We still have, significant percentages of patients, whether they are having no digital ulcers, so only Reynolds phenomenon, or they have had like episodic or maybe like recurrent or chronic digital ulcers. You can still see that significant number of, these patients, unfortunately, still undergo amputation or infection or either hospitalization, increasing the cost. So I think we have still a lot of unmet needs in the management of these patients. I think one of the most important unmet needs is like earlier recognition of these patients just by performing, nail fold capillary and trying to expedite the referral of these patients to rheumatology, where they can get like the correct and the right management at the right time. Now, not to forget the importance of local treatment. Local treatment can always decrease or reduce the requirement or the need for vasodilator therapy in these patients. And I think we were discussing that today at the poster session. So reducing the movement, keeping the wound or the ulcer clean, minimal debridement, as well as applying some protective cover dressing. These all can help expedite the healing of digital ulcers in these patients. Now, so the patient that we had in our clinic at the beginning of, and then so this was like the last week. So this is the patient who we started, we had him on IV alprostadil. And then only 2 months later, there is a typo error in the, so this is March, that was January. So you can see that we were able to prevent or heal the digital pits that were in the 5th digit, as well as some of the ulcers. However, she already had an O2 amputation in her left middle finger. But this was a very reassuring picture that this patient was able to send us last week. We admitted her for IV prostaglandin. We applied some wound care, IV antibiotics, and we discharged her on oral antibiotics as well. Vasodilator therapy, she's now on calcium channel blocker as well as phosphodiesterase inhibitor and statin, and luckily her blood pressure is allowing us to do all of that. So again, this is a typo, so these are my conclusions and not local treatment. Digital vasculopathy is a common clinical problem that is encountered in systemic sclerosis patients. Each patient requires individually tailored treatment, and special focus should be paid to other comorbidities and blood pressure. Recent advances in treatment have improved outcomes, and multidisciplinary approach is always important to be able to provide effective managements for these patients. With that, ladies and gentlemen, Mr. Chairman, I come to the end of my talk, and I would like to acknowledge the team that is helping running this clinic at a Noor Specialist Hospital. Without their help, I think we cannot run this complicated clinic. And thank you very much for your kind listening and attention.